And we're live.
Great. Thank you so much. Good morning, everyone. Welcome to my Facebook Live conversation on mental health in Canada. My name is Julie Dzerowicz. I am the Member of Parliament for Davenport, and I have four wonderful panelists with me who are going to have a discussion on mental health and how is it that the federal government can better support mental health across Canada. Before we begin, I'd like to start off with a land acknowledgement. We acknowledge that the land we're meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee, and the Wendat people, and is now home to the many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. So with that, I wanted to just maybe give a little preamble before everybody introduces themselves. Mental health is a long-standing issue within my riding of Davenport, and I know it's in Toronto an issue and right across this country, but I'll be talking very much from the perspective of Davenport because that is what I know best. The amount of conversations I have at the door with parents or with people who are struggling with mental health issues has gone back to when I was first elected in late 2015. And the issue has become even more acute as we have gone through an unprecedented pandemic over the last year and a half. And so as we're coming out of COVID, I felt it was a very important conversation for us to have to see how is it that the federal government can better support mental health organizations, mental health objectives, and Canadians who are struggling with mental health across this country. We all know that healthcare is run by provinces. It is a constitutional responsibility of our provinces and territories. So the federal government has largely been focused on providing large sums of money to the provinces and territories. And in my mind, how is it that we can be far more effective in terms of making sure that that money gets to where it needs to go from an organizational perspective and from a people perspective? And I'll mention sort of two key things. In Ontario a few years ago, I think it was in 2017, 2018, an additional $2 billion came from the federal government for mental health supports in Ontario. I've not yet found any organization in Davenport specifically that has benefited from those dollars. And so it's made me question, where is the dollars actually going? It's probably going to some really good spots, but maybe we could actually target those dollars better. I also wanted to make sure that everybody in our audience knows that in Budget 2021, which was introduced end of April, we did propose three key things. We proposed to develop national mental health standards. We have also a promise to continue to invest in mental health for those that are impacted by COVID, and particularly in our Wellness Together Canada portal. So that's kind of what we've put in Budget 2021. Just when I reread that this morning, I thought, wow, that's not much. We need to do far more. So that's why I'm really glad that we have four panelists with us today, and I'm going to ask each of them to introduce themselves before we get into the first question. So we have Roslyn Shields from CAMH. We have Toban Black from our community, from our Place Community of Hope in Davenport. We have Tina Shapiro from Sistering, also in Davenport, and we have Lara Iserman from Sistering as well. So a huge welcome to all of you and to everyone who's listening. And before I begin, because I have forgotten this, I want to give a shout out to the woman who's inspired this conversation. Her name is Andre Paulin, a Davenport resident who is very passionate about this issue. She's the one who's largely really set this up. And I just wanted to give a shout out to her and thank her for her inspiration and for her hard work on this. Okay, so Lara, maybe I'm gonna ask Lara to go first, followed by Toban, Toban, Tina, and then Lara. So Roslyn.
Okay. Hi, everyone. My name is Roslyn Shields. I'm a senior policy analyst at the Center for Addiction and Mental Health, CAMH, where my public policy focuses are mainly mental health, social determinants of health, and the criminal justice system. I've been in the mental health field now for 20 years, most of it at CAMH, with a variety of roles, including direct service and research. And I'm just really excited and happy to be here today to discuss mental health with my fellow panelists. So thank you.
Hello, everyone. I'm
Oh.
Toban. I'm a mental health drop-in worker at our place Community of Hope. I am also a Toronto Distress Line volunteer. And at the drop-in here, we provide a social space. We provide recreational activities, and we have a meal program. We do referrals. And our drop-in is part of the organization St. Michael's Homes, which also provides addiction treatment and housing. But I'm here to speak for myself about my own experiences talking with people individually and in groups.
Well, welcome, Toban. And Roslyn, I said welcome to you as well, but I was muted when I said that. So thanks to you and all the amazing work that CAMH does. And Toban, we love having, our place Community of Hope in our Davenport riding. Okay, next we have Tina.
Hello, everyone. My name's Tina Shapiro. I'm a program coordinator at Sistering, and I've been with Sistering 10 years. Sistering is just celebrating our 40th anniversary, and a big chunk of that has been in the Davenport riding. We work mostly with homeless women or women at high risk of experiencing homelessness. A very high percentage of them do have mental health issues, some have substance use issues. And my own specialty, which I would like to talk about more, is mental health from an impairment perspective. Thank you.
Thank you. And it seems like your dog or cat is also saying hello to us. Okay, Lara, over to you.
Good morning. I'm Lara Iserman. I'm a community support worker at Sistering within the case support team. I've been at Sistering for 15 years and in the social work field for 19. The work that I do is pretty much from a trauma-informed and anti-oppression framework. The main focus of the work that I do is connecting individuals with agencies, resource navigation, working with individuals with complex mental health needs, substance use, trauma-informed, getting them access to resources, housing, legal supports, financial supports, connecting them with other agencies that they would need case management services for. A lot of it is also eviction prevention and trying to get counseling supports. Thank you for having me here.
Well, thank you for being with us. And, I mentioned this a little bit at the beginning, but I want to reinforce it. My ultimate objective with this conversation today is really, how is it that the federal government can be more supportive on mental health in Canada? As we give dollars down to the provinces, how can we be prescriptive without putting a chokehold on all the criteria in terms of how the money can actually be spent? It really, to me, is about how do we make sure we get the dollars to the organizations and the people that need it. The other thing I just want to mention is just the 2 or 3 things I've heard of the doors. I do hear issues around more and more of our children being more anxious in schools. I hear a lot of that. I hear it from principals. I hear it from teachers. People who've been in the system for 20 years will say it is absolutely surprising about the stress. I hear about older adults and just them not even be able to get into the system, or the waits are 1 to 2 years. And they're traumatized by it because they need the support right now. And the last thing that is very particular to my riding of Davenport, 43% of my riding is actually born, are first generation Canadians. They're born outside of Canada. Their first language is not English. And so many of the supports or resources that are out there are in English mostly, some French, but that's about it. I know that there are some specific supports in different places that offer in certain languages, but I know that that's been another key issue that's been raised. So I think with all that, I'm going to start off maybe with, I think we should just sort of do a level set. So what's the status quo right now? How does mental health care work in Canada? And maybe if we could just do that level set. And then what I wouldn't mind is then we could start going into the conversation about, I had mentioned that the federal government had invested over $2 billion here in Ontario, and whether or not any of you have actually benefited from those dollars. So maybe we'll talk about what the status quo from your perspective is, what are the current needs, and then we'll go into the next question. So maybe I'll start off maybe with Lara. We'll start off with you, we'll go backwards, and then we'll go from there.
Okay, I want to acknowledge, yes, we've been open for 40 years, and the only reason the string opened it was created to address the impact of the deinstitutionalization of mental health services and the closure of the mental health facility, especially Queen Street Mental Health Center. So when I look at the status quo from then, it has significantly changed, but not enough to make a change as of today. For me, it's been a revolving door for a number of our clients that have been homeless, chronically homeless, and have had mental health, whether it's a diagnosis or not. But, we call non-emergency the MCIT teams, and it takes hours, 3 to 6 hours for them to come to address. Sometimes when they do get this, uniformed officers that do come. So the outcomes for the individuals that we work with might not always be positive. And individuals are taken to a mental health facility or to the emergency, but discharged back into the community within a day or two without getting any collateral information from support. So it is a revolving door. There's a lot of agencies we need to get involved just to get an individual to get access to, better healthcare and treatment. And even that hope is never given to them. So I think it's a struggle. Talking about the increase in funding, as a frontline worker, I've not seen that. I've not seen any changes in that. I can't get access to services for my clients. And I think a lot of them that I can get access to services that are free are through community health centers, which the wait times are longer. So I think if anyone else is getting those dollars, we're not made aware of that.
Okay. So Tina, would you have anything to add to that from a sistering perspective before I go to Toban?
Yes, well, we did receive some funding dollars in the form of some big research projects we've been involved in. And research definitely has its place, but I would like to echo Lara from a drop-in perspective that people sometimes will go someplace like CAMH, since we have someone here from CAMH, and just be there for a day or two and back a few weeks later. And there may, in terms of our participants, actually be a class differential in terms of how long, and maybe even an anti-racism, anti-oppression perspective is there too, in terms of how long someone will be at CAMH and maybe not get the support they need. And we do only use that actually as a last resort. So I think that is very important to understand. And one thing I wanted to focus on, maybe coming out later in your questions, is that mental health is very tied also, as Lara was bringing out, to issues of housing and employment. And, just targeting mental health dollars isn't enough. What people will tell you they really need is a good place to live, a job, a friend, to quote one organization. So those aspects are very important as well.
Okay, thank you. And we heard that loud and clear, actually. Without that stability, how do you actually how do you be in a place long enough or stable enough to be able to sort of get the care that you need? Okay, Toban, over to you. And then Roslyn, fitting that you will sort of end off this question.
Okay, thank you. So to add to what's been saying, even though the crisis services are so limited and sometimes often problematic, that's how people initially access the system in so many cases, unfortunately. So there's very limited care for people who aren't high risk of suicide or people who are accused of violence. So the system is really focused on survival, more so than actual recovery. And a lot of the resources are concentrated in hospitals focused on a medical approach, whereas out in the community, we're trying to deal more with all of these intersecting conditions that have been mentioned, poverty, racism, immigration issues, and so forth. With the very limited resources that we have, we're trying to grapple with all of that as much as we can. Whereas a medical approach, doctors are far too quick to apply labels and to focus on supposed dysfunctions, illnesses, instead of trying to empower people and focus on solutions and ways forward. And medications are highly overrated. They can help people, certainly, but they're generally not a cure. People need help with coping skills and the kinds of supports that we're talking about. And that's often missed in a medical approach. And when medication does help people, it's often a stopgap to allow them to get therapeutic support or case management support or what have you, to kind of make some more space for that. And there's always side effects and trial and error. And I work with people who the side effects leave them very, very impaired, frankly. Drowsiness, cognitive issues. So that's problematic, but for more common depression and anxiety, medications are generally all there is in terms of support from a family doctor. There are other odds and ends out there, the distress line and so forth, but they're not being accessed much because navigating so difficult, and there's just so little there. It's just such a sparse patchwork out there. And so when someone isn't in crisis, then they're left to try to navigate that themselves. And then if they do reach a crisis point, they might receive enough assistance, they might not, as my colleagues have been saying. It is a revolving door. People are sent out far too quickly. And there's a lot of gaps in the system, a lack of trauma support. I work with people who deal with psychosis. That is, they see things, they hear things, they have a cognitive disconnect from reality. And supports out there are focused on first episodes and early psychosis early in life. Afterwards, there aren't really significant programs out there. And these are just a couple of examples of important gaps that I see. So there's so many limitations to the services out there. And one more point I'll make for now is that when people do go to hospital, it can be a very disempowering and sometimes a traumatizing experience. You know, the sad reality is that there's some coercion going on in these institutions. People are being held down and forced to take medication. People are being sat on by security when they're in a desperate state. And then there's problems with the dangers with the crisis response. We've heard some of that from the Black Lives Matter movement, fortunately, and there has been some response. But accountability in hospitals for coercive responses to people really needs to be talked about. So there's a lot of room for reform and improved funding, especially to community services, and lots more to say.
Okay, thanks so much, Toban. That was really helpful. Roslyn, we'll have you round out, and then I just want to sort of, and then I have a few small follow-up questions on this.
Okay, so I'm not going to speak from a clinical perspective. That's not my area of focus. You know, I do want to respond to Toban's assertions there and just say, you know, that is, from my perspective, not something that happens at our institution. And I'm sorry to hear that you've heard that that's happening, but you know, that's something for, I think, another conversation. But what I want to get back to, Julie, is talking about things that happen. You know, as you mentioned, the federal, the health transfer gives the federal money to the provinces. So the healthcare, mental health care is in the hands of the provinces. So I'm not going to touch on this question, but I'm hoping that we can touch on that a little bit as we move on. But just what I want to focus on is what the federal government can actually do with within their realm, right? So, you know, if we look at the early days of COVID, the government, and you mentioned this, launched the Wellness Together platform that provided access to information and supports for people who were struggling. That was fantastic. The government also announced the CERB to assist those that had lost their jobs during the pandemic. So knowing that someone has a reliable source of information is income, especially during turbulent times, goes a long way to supporting mental health. And I know Tina mentioned, the social determinants of health in general is really crucial to mental health. So similarly, we know the government worked with cities to develop rapid access to sort of shelter-like options, such as hotels, for people that were homeless during the pandemic and didn't feel comfortable staying in traditional shelters. Now we know there's obviously been some challenges with that program itself, but the idea that we can be focusing on housing and income, I think are really, really important. And I think are an area that where the federal government can make a dent in the short term. You mentioned the recent federal budget, so money going to the Canadian Suicide Prevention Services. Excellent. Continuing to invest in, putting money towards the mental health initiatives that for people that were disproportionately impacted by the pandemic, and the investment in the mental health and wellness strategy for Indigenous people. Like, those are some of the really key pieces that we would like to see the federal government continue to invest in the short and the long term. And then if we want to move to the next question, I can talk a little bit about that investment that you've made recently.
Okay, so I just want to pause for a second because I think it's really important, because I think what we've heard is housing is really important, jobs and or some sort of a stable income is really important. I've also heard you, Toban, that I think just even within the medical profession, sometimes I think, and this is a generalization, and this is in many different aspects as well, sometimes we have more of a one size fits all, whereas we really need individualized supports. And I often wonder, sometimes I wonder, which country might be doing it well. Canada's a federation, so you have a national government, and then you have, provinces and territories, and each of them are running things a little bit differently. So anyways, I think it's an important point to mention around the doctors, and I think, is there work around that? That wouldn't be anything federally we would be doing, although what I would say to you is, and I wouldn't mind hearing in a subsequent answer if you have a comment around this, national standards. One of the key things we want to work together on is proposing to develop national mental health standards. Do you think that will be helpful? And how can we make that most helpful? So I wouldn't mind mentioning that. I do want to say in the south part of our riding, we have started creating modular housing or rapid housing. And south part of riding, it is supportive. And we know that, I think that all of us at the federal level knows that you can't have this rapid housing or modular housing without it being supportive. We do know that there are mental health supports, and it is full-time sort of in the facility in the south end of Davenport. So I know that we've identified this problem. I know we've started putting quite a bit of money around that. And I wouldn't mind hearing some of your thoughts, whether you're thinking that that's been a positive, whether we need to do it slightly differently, or if you're seeing something that we're not doing or we could do that better. The other thing in terms of income in jobs, one of the ideas that's been proposed, and I know I introduced this in the House of Commons, is a guaranteed basic income. We're very blessed in this country. We have a social welfare system. It was actually created in the 1940s. I actually looked it up. It was majorly modified in the 1970s, and we've band-aided the solutions, and we've kind of adjusted it all the way to today. But in my opinion, it's not. We have an outdated system that doesn't meet the needs of Canadians in the 21st century. And I would say it would, in particular, those who have mental health issues. And so I wanted to see whether or not you thought that might be a model that might actually be helpful as we move forward. So for the next question, and I think, Roslyn, I'll get you to get started, since I think you wanted to respond to it, is there has been over $2 billion in investment given to the province of Ontario. We've heard from a couple of organizations that have said, well, we haven't seen any in Davenport. CAMH is a couple of blocks outside of my riding, but I know that you serve your Toronto-wide, which is really great. So I wouldn't mind hearing a response from you. The other thing I wouldn't mind hearing, and Roslyn, you might not know this, and it's only because I discovered this. I was up at Pelham Park, and I don't know if you know that part of the riding. It's up near Osler and Davenport. We have, it's probably among the poorest of my facilities. What I learned from meeting many people in the building, and people who've been there for a while, is I believe it was in the 1980s or early 1990s, CAMH used to house a lot of people with mental health issues. And then they closed down. So there was, I think, a conservative government in Ontario. They closed down sort of the housing of people with mental health issues. And so with the idea that they should go out into the community and be supporting the community, what ended up happening is that the building in Pelham Park, it was meant for seniors. So we have half seniors, and then half of it is with those that have mental health issues. So they moved out of CAMH and they moved in. And again, I only just realized this, and I'm almost embarrassed to say this because I've been an MP for 5 years and about 7 months now. And so, but they don't have any supports at the facility. And so, how this mismatch where you've got all these beautiful seniors and then you have a number of people who are also beautiful with mental health issues. And it seems like it's been the only place that they've been able to sort of actually find a safe place to actually call home. Anyway, so I'll turn it to you, Roslyn, and then I'll go backwards again to Toban, and then Tina, and then Lara.
Great. So just to respond quickly to that first comment, I don't know about Pelham Park. I know that CAMH has, so we don't actually and never have had housing that belongs to CAMH. So what we would do is have housing partnerships with supportive housing agencies. So it is possible that a supportive housing agency manages those units, and it may be CAMH clients that are in there, but the housing support should be provided by the agencies. Many, if they're still CAMH clients, that they would receive clinical services from CAMH, but the housing supports would be provided by the housing agency. So it may be worth trying to figure out who's actually responsible for that particular housing. So back to the investment. I mean, it's great. It's fantastic that it was announced. But I think, just to put it a little bit in perspective, so in England, 13% of the healthcare budget goes to mental health. And in Canada, we're at about 7 to 8%-ish. And so while this investment, kind of starts pushing us in the right direction, it's just, it's not enough. So that's one big challenge. The second challenge is, and you did allude to this a little bit, is that the funding that you guys provided, the feds provided to the provinces, it didn't require any transparency or accountability from the provinces on how it was spent. So we really don't know how that money was spent at all. And we heard from my fellow panelists that they're not seeing it on the ground, and we're not seeing it on the ground either. So what we see on the ground is a continuation of really long wait times for mental health care and treatment, inconsistent service quality, a confusing system that's really difficult to navigate. And then people don't have access to treatment. So Toban was mentioning, like medication. And yes, that's one option, but there are other non-medication type treatments that people don't have access to. And one of those is cognitive behavioral therapy, which is a life-saving treatment for people with mild to moderate depression and anxiety, but it's not publicly funded. So that is some of the concerns that we're dealing with on the ground. So while, investments and further investments from the feds are needed in mental health care, I think we really needs to come requiring that transparency and accountability from the provinces.
Okay, that's very helpful. Thank you. Toban, back to you.
Okay, so I've heard that there has been funding for larger organizations and hospitals. It certainly hasn't reached us. Of course, we're all part of the same sector. There's various partnerships and referrals, and money into the sector is absolutely needed. So it's valuable, but none of the funding's reached our organization. We receive 3/4 of our funding from charity, and there is a degree of healthcare funding that comes to our organization. It's more for addictions, and then here and there we receive some mental health funding, and then food security and drop-in resources. And we do what we can with what we have. I don't personally work with grants. I'm here to talk to people one-on-one and try to show empathy, bring up people's strengths, work with people directly. So this is all kind of over my head. But in terms of what I'm seeing in the sector, in terms of where we're at with the funding that we have, housing, I mean, yes, there are some positive initiatives, but I talked to various people who are living in infested housing that's noisy, there's more violence and break-ins. And so these rooming houses and community housing situations are not places for healing in many cases, and definitely need more funding there. And people need more access to counseling. What's out there tends to be on a group basis. Of course, one-on-one therapy is very hard to come by, publicly funded. Generally, you either have the money in your pocket, you have benefits, or you take what you can get in terms of group programs, or maybe calling a distress line and talking with someone, possibly only for 20 minutes at a time, different person every time. That's some of what's out there. And the programs that are available often are very standardized. A lot of people do benefit from CBT, absolutely. There are more individualized types of counseling that can get into someone's personal experiences more. And again, trauma support out there is a severe gap in the system, because trauma, in large part, what we call mental illness, is an expression of past traumas, and people are not able to get supports to work through those and heal in so many cases. So there's so much more we could be doing if we were trying to build a system towards healing and recovery and moving on, instead of being dependent on what's out there. And as to the question of national standards, we certainly could. There's a lot more that could be done there, and just conversations about what's happening and what will allow us to move forward. There have been reports from the Mental Health Commission, and the Canadian Mental Health Association has some policy statements that are useful. But these kinds of discussions are very marginalized, and so this platform is important right now, and we need more of that, and need to put things into words more concretely, and so this is a positive step.
Okay, great. Thank you so much, Toban. And I appreciate your comments on the national standards as well. Okay, Tina, you're next, and then we'll end off with Lara.
Thank you, Julie. So in response to some of what you said, definitely one concern I'm hearing from our peers in particular at Sistering is people are very worried about the beds in hotels. What is going to happen to those beds once the pandemic is over? What will happen to those people? So definitely, things like the modular housing, I think, are a positive step. In terms of providing, some basic living spaces that are private for people. And I think we really do need to focus on housing system-wide, as well as programs to help people with employment and job creation. And definitely some people have you yourself have touched on that so many people are newly affected with mental health during the pandemic with the self-isolation. So I think more of a response to help people newly into the system. I do really very much appreciate people's emphasis on things like trauma-informed, anti-racism, anti-oppression. I did want to add to that the perspective of the MAD movement and the MAD community, which is very strong in Toronto. So one rallying cry is nothing about us without us, which actually is borrowed from the disability movement. And so if you're talking about funding dollars or policy, you really need to ask people how they would like the money to be spent. So in addition to the medical model, which is what we've really been talking about today, there's things like the recovery model. CAMH uses the term recovery, but it comes from a movement of consumer survivors, which are people who identify as using the mental health system or having survived the mental health system. And they put forward things like, okay, if you are going to spend $20,000 this year on my mental health, I want to say in how that's going to be spent. And maybe I would rather spend that on my education so I can get a better job, or just ask me how I want the dollars to be spent. So the last major consultation was in 2007. As Toban mentioned, the Mental Health Commission of Canada, that's a bit old, but there is quite a bit written. And MAD is a reclaimed term, taking back negative stereotypes and language and turning it into a positive political identity. And there is a very rich community in Toronto that there's Mad Pride Toronto. It's fizzled out a little bit, but we do take pride in our individual identities and our identity as a community, our accomplishments. So it's not always coming from a medical model and a deficit model, but it can come from a place of empowerment, and to really recognize and to come from a strengths-based perspective, and to really, first of all, if you're talking about money, ask people how they want it to be spent.
Okay, thank you. Lara, do you want to finish up this sort of round?
Yeah, so I do agree with my colleagues. And I think, you know, when we talk about mental health, a lot of times trauma is spoken about. And, you know, I think not everybody understands how trauma impacts individuals and how that impacts their behavior as well. So when it comes to, you know, it doesn't have to always be medications, because that's one component of it for a mental illness, but I think it has to be a wraparound services. So access to talk therapy, CBT and DBT works wonders for a lot of individuals that we work with, but that's only through certain programs, and sometimes could be group therapy. Access individual programs are very hard to get. And I think, you know, it's really sad that OHIP does not consider psychotherapists as, you know, in a medical field. So if we look at it at national standards, I think I reviewed some research done in Australia where they've actually made it accessible to all Australians to access mental health through their medical funding system. So we always wait for individuals' mental health to deteriorate. We don't do it as a preventative measure, and that is why we're in this situation. I think it's, for me too, talking about the with housing, we talk a lot about 24-hour supportive housing, and I think I haven't seen changes at all into where that federal funding money has gone into housing. The access point application is longer, the wait times are much longer, and for me, 24-hour housing has to be where there is mental health supports on site. Staff are already overworked in that, and also because they're their landlords, they also are the support agency. So there's always that conflict that happens there. So, you know, I've seen that so many times where we have to do advocacy with the landlords. And there are two things I can talk about too as well with the city's new project about the Rapid Rehousing Initiative, housing individuals that are homeless into Toronto community housing. I think that's a great opportunity, but the city has done a lot of work in that. However, it's the requirement is individuals with low needs. What happens to those who have complex needs? Where do they go? So that's where the problem is always there. I've had, as of 2 days ago, a partner through Access Point reach out for housing clients, but it had to be low needs because they don't have the capacity to support individuals beyond that. The other thing that the challenges I've seen from last year was detox beds. I could not get a bed at all. And I've been doing that for 1 year, trying to look at access to detox beds for clients. And it's been really challenging. And if somebody does get access to those detox beds, it's not trauma informed. There's no therapy or supports in place for that. And it's been challenging. So we further push people back into the system of, you know, trying to navigate a system they don't know. And we talk about language and cultural components to this as well, right? So how does somebody know or access these resources if it's not made known in different formats for people to access?
Okay, So important and such good information. So I'm just going to sum up quickly, and then I want to actually go to sort of finalize with a final question with something that Tina said, and then have each of you guys give your final comments. So for me, what I'm hearing is we just need more money. I think that it's very stark when you say, and I think it was you, Roslyn, when you said in the UK, 13% of healthcare overall goes to mental health, and in Canada, it's around 7 to 8%. I think that's very stark. And I think that when you start seeing that, and I wonder if we look at other major countries around the world, whether it's more or less similar. So I think that it's just more money needs to be allocated. So this is overall, and it seems like, and that's at all levels, and it starts with the federal government too. When we're giving dollars down, whether it's provinces or territories or grassroots organizations or whoever, it has to be accountable and it has to be transparent where the dollar's going. I think it also allows us to see where the dollars are working, and the fact that we're not doing enough of that, I think, is troubling, and I do think it needs to be addressed. I'm hearing very clearly supportive housing is absolutely critical, and I do note the message about, okay, thanks federal government. And so just in case those who are listening don't know, the federal government has been giving the cities dollars to rent out hotels, temporary shelters, so that we could provide those who are vulnerable, those who don't have housing, particularly the homeless, to be able to have sort of independent sort of hotel rooms with, little kitchenettes and places to stay. But I know it is a pandemic type of response. And I do think there's a very valid question about, well, what next after that? But housing and supportive housing is critical. Next is job creation and income support, I think is the sort of fourth category that I have that I think needs to be part and parcel as part of our solution moving forward. And the fourth thing that I have here is incentives. This is something that I'm seeing Joe Biden do in the United States, and I'm paralleling it with climate change. He's providing a lot of money from the national level around infrastructure down to the states, but he's putting a lot of criteria. We'll give you this money if you're spending it in these key areas. And so what I would say is maybe this fourth category is us looking at incentives from the federal government to say, we're going to give you additional dollars for mental health, but you have to improve your rooming house standards. You have to make sure that there's better access to therapies like those like programs addressing those that have traumas, and more access to talk therapy. And I would probably add those in multiple languages, just because not everybody speaks English in our city. I also would say that there needs to be far more access to detox beds. And so I've put that as well. So those types of things I think we can do at the federal level. And so that kind of leads me to, so that's what I'm hearing so far. And I wanted to sort of just summarize that. So the last, and I think, Tina, you said this, ask people how they want money to be spent. And so this really gets to the crux of where I wanted to take this conversation about, if the federal government is sort of moving on next steps, and we said, well, we have a big pile of money, we want to sort of allocate it to mental health. Is it so that we do something like we work on the overall strategy, and or do a major consultation like the one that was last done? I don't know when it was last done. I think someone said 2015, 2017, 2007, I'm not sure. Is it that we need a big national strategy? So that's part one. And then part two, should we be doing things like what we're doing right now at the federal level? So often we're bypassing the province in many cases, and we're just directly either going to the city or directly going to grassroots organizations and providing funding. So and again, that's not to say give no money to the province. They obviously run our healthcare system. We absolutely need to sort of support that. And so please don't think that that's what I'm proposing, but I do think that maybe there could be flexibility in terms of where we actually direct those funds. So if you could provide some advice and maybe recommendations around that, that would be great. And Roslyn, if it's okay, we'll start off with you.
Okay, well, thank you. So, I mean, I think there's a lot of exciting opportunities for the federal government and how to support Canadians' mental health. So I agree. I think there's space for both direct funding to the provinces for care, as well as some of the other opportunities you mentioned. So I was pretty excited to hear you mention the basic income. I think there's a really important opportunity there, and I would love to see some more movement on that. I think, just the ongoing focus on the social determinants of health, poverty is something that the feds can really make a big dent in. One of the things we didn't talk about, but I think is is a really important place that the federal government can make a big dent is in mental health research. Right, like there is, if you look at the funding of mental health research compared to cancer research, like it's a drop in the bucket. It's not a lot. And if we were able to invest and provide money to our scientists, I think we could really see some major discoveries when it comes to prevention and interventions, treatment for mental illness. So I would suggest that's the another place. And I do like the idea of the system, like of focusing on the system level work that the federal government can do. So you met the national standards, fantastic. I think that's a great way to start. I think there's another opportunity for the federal government to be looking at data collection and analysis, working with the provinces on a wait time strategy for mental health care. So those system level pieces, I think, are obviously important, in addition to the increased funding for direct mental health care. And when I say mental health care, I mean, across the system of mental health care. So from community supports to, more crucial and acute mental health care.
Okay, perfect. Great. Toban, over to you. And I just realized that I should have started with Lara, but anyways, obviously I haven't had my coffee yet this morning. So this is why, so I apologize, Lara and Tina. Okay, over to you, Toban.
Okay, here I am. Thank you. So first of all, I'll say that mental health is not a priority right now in terms of the platforms of any of the parties that I looked at. And so that needs to change. And we could be taking more of a preventative approach that is focused on actual recovery. And as for how the money can get to where it needs to go, I'm not going to pretend to understand. What I hear is that the province is not prioritizing community services, which I would suggest needs to change. We need to rebalance things somewhat towards, we absolutely need medical funding. That's crucial in the picture, but community services need a bigger portion of the funding. We do more with all of the dollars that we receive. We provide more human connection, and we have that emphasis on the holistic approach to recognizing people's financial situation, their social situation, their housing, and so forth. And it's not black and white. There's social workers in hospitals, and there's partnerships, and it's all very complicated, but community services need to be prioritized more in this picture. They can be more accessible and less distant. And so what we do here, as I said, we're a social and recreational space. We help with social connection, which is really crucial to recovery and to wellness. Having relationships, being with people who can understand, having opportunities to express yourself. That's part of growth. That's part of recovery. And finding a path beyond, illness or so-called illness. And we've heard about trauma care and awareness a little in this panel, a very crucial. I'll say that in regards to a trauma-informed approach, as my colleagues know well, even when we don't have opportunities to provide ongoing trauma care, which can be very in-depth to actually work through someone's history, more of us in the field can be trained to be sensitive to possible traumas, to recognize that anyone may have a trauma history, and that in focusing on their strengths and being collaborative, providing people with options, to simplify, I'll say it prevents making things worse for people, and it can help with healing for people. And so we need more of that trauma-informed awareness, and not just in our sector, but also in education and as much of Canada as possible, basically. It needs to be a kind of paradigm shift for how we approach mental health. And part of that is just helping people with basic coping skills, like deep breathing or journaling or things like that. And so many of us can benefit from that. We all have stress. Stress worsens mental health symptoms. Finding ways to help people with coping and stress is going to help with mental health for everyone. This isn't just a question of what people who are struggling more need. This is about wellness. This is about, dare I say it, it's about happiness. So there's so much potential here and so many sides to this. And there are suggestions out there from existing organizations, and these messages need to be heard. These survivor experiences, as Tina mentioned, and people in the field who are trying to articulate what's missing and what the way forward is. So again, thank you for the opportunity to start to hash all this out.
No, I appreciate your comments, and I really appreciate you mentioning I think a lot of people, just in general, unless they've worked with people who've experienced trauma, don't really understand the impact it has on your lives and the fact that it actually can stop you from doing anything normal in your life if you actually don't address it. And I really appreciate your comment about saying we could focus a lot more on preventive. I've actually read a lot on trauma. Bessel van der Kolk is someone I've read quite a bit on. I'm actually a child of trauma, so I actually have personal experience. So I know that if you don't have any type of stability or way to be able to sort of be in a safe place to be able to deal with it, that's why housing is so important, and having an income so you could eat is so important. And people, if you don't fundamentally understand that, you actually don't fundamentally understand how we're going to actually really address this issue. Okay, so thank you. Tina and Lara, to end off.
Julie, I want to thank you for sharing that and really leading us by example with your own life. Thank you. Definitely at Sistering, as Lara was saying, we try to approach everything from a trauma-informed lens. It's so important, from service design to service delivery, and just really how we work with the women and trans folks. It is absolutely key. And I think, as Lara was saying, more trauma-informed services are key. I feel the city has a gender equity lens for reviewing all policy and funding. And I do feel like that is critical as we move forward to hold the city accountable to that gender equity lens. I wanted to address also what you were saying about basic income. A lot of people think it's a great idea. There is a bit of a critique in that, whereas it does catch some people who may not have access to ODSP, OW, or CPP. Also, the dollars go to everyone, so it can go to millionaires or billionaires. So some of the money is wasted, and also in the long term, some of the benefits that people do have on something like ODSP get lost. You don't necessarily have as much benefits for, I believe it's things like drugs and eyeglasses and things like that. So there are some concerns. But just mostly, I know we just have a minute or two left. I wanted to thank you for opening up this dialogue, and also via social media on Facebook. I think dialogue for me is the whole heart of what we need to move forward, whether it's in mental health or just generally in addressing systemic barriers, systemic issues. It really is the way forward. So thank you.
Thank you. And Laura, before you sort of get the last minute or so, just for a guaranteed basic income, I have talked to disability advocates, and so I appreciate your comments, Tina. No guaranteed basic income program should go into effect without the principle of everyone is better off. And the operational design of the program is absolutely vital. You know, it has to provide people with sufficient income, discourage fraud, encourage people to work. You know, overall, it has to be a positive benefit to Canadians. If not, why introduce the program? Lara, over to you. I think you get the last minute.
So basic income, as I recall, was started sometime as a pilot project in 2015. And I don't know what the outcome came about that, because it was supposed to be started somewhere in Ontario. Heard about it, heard a lot about it, but never heard about it after some time. So looking forward to hearing where that goes. I think for me, what I would like, I mean, there's a lot of different things that's happening. I'm trying to figure out if this is where the funding dollars have gone now. So I know that there is the Reach Out Response Network that Council approved, which is a civilian-led network with individuals with lived experiences. They put out a report on the international response to mental health crisis, trainings and best practices. So they're an alternative group to police involved in crisis response, and it's a pilot project that will be starting next year. Then, when it comes to MCIT teams attached to police, it was really hard to get an outline of how many there are. And I just found out that on the Toronto Police website, there's been an increase from 10 to 13. But it doesn't say much, like, is that where our funding dollars are going for mental health? Are they getting the mental health training there? And how beneficial is that? I'm also looking at, the social rehabilitation of individuals back into society. Even though we're in phase 3, it doesn't mean that the anxiety and mental health has changed with the social isolation. So looking at funding and resources for possibly virtual counseling to bridge the gap so that they can have the face-to-face counseling support so they can integrate back into the community. The other thing too that I think might be also fed, I don't know if again it's mental health dollars going to, is Gerstein Crisis Centers partnering with the Toronto Police Service. So they would, and that would start next year as a pilot project. But I don't know what's starting this year. And that's the thing, everything is moved for next year. So things like that, I really want to look at. I go into people's homes, I do home visits. I know how much and how they've been struggling. And I think, when we look at a lot of our clients are housed in Toronto community housing. And I think a lot of the times is police are called when it is a mental health related behavior and incident. And I think that their security as well as the staff need to be trained on, the difference between mental health and sensitivities around that. So that reduces a lot of police involvement, because that also brings about triggers and traumas with them and escalation in behavior. So there's a lot of things that money can go towards. I don't know, like I said, as a frontline worker, I don't know where that money is going because I haven't actually seen those changes. And, it shouldn't be where we are far removed from that. I think, and just like Tina said, ask people where they would like their money to go to.
Well, I appreciate that, Lara. And, I just on the basic income program that Ontario had put in 2015, that was actually canceled by the Ford government as soon as he came into office. So that's why you haven't heard anything. It wasn't allowed to finish its pilot. It would have been very interesting for us to have figured out the data on that. So hopefully at the national level, I've introduced a bill, but if we have an election, the bill sort of goes off the table. And so if I'm blessed to sort of be reelected, if there is an election, then hopefully we'll be able to reintroduce it again. So
thank you. Just before we go, I think you mentioned about modular housing, and I know that we have a few near Sistering, but I think the challenges about that for our participants is it's close to 14 division, and that's a big trigger for them. And I think it hasn't worked out for them. So I don't know, what those options look like. If there are different options, spaces.
Yeah, no, I think that's a great point. So I'm going to end off just because we could actually have a big conversation about that for sure, because that's a big conversation in the community. But here's what I'd like to end off with. One is just a huge thanks to all 4 of you, Roslyn Shields from CAMH, Toban Black from Our Place Community of Hope, Tina Shapiro, and Lara Iserman from Sistering. Thanks for this genuine and heartfelt conversation. I think this is how we're going, these types of conversations is how we're actually going to get to the real solutions. That's going to ensure that whatever resources we have is going to get to where we need it to go. So, so thank you for being part of this conversation. This to me is going to be the first of many, and I'm hoping to bring on some additional people who have also, whether they're at the provincial level or at the municipal level, that we could start saying, well, how do we continue to move this bar forward? So a huge thanks to you. Thanks to everyone who's been listening in on Facebook or who will be listening in. And I just want to wish everyone a wonderful day. And thanks for all the important work that you guys do. Take care.
Thank you.
Bye-bye.
Thanks.
Thank you.